Good morning. Hope everybody's good. Just see here. Sorry. This morning. Really good. Okay, I think we'll give it 30 seconds and then get going. I think this is fine. Okay, let's get going. Alrighty, this is a tracing from my friend Dr. Savli, who's a extraordinary cardiologist, lives in Cambodia, pretty much does everything, echo, fetal echo, post-op care, a little bit of EP. So he posted this electrocardiogram online and said that this was a 2-month-old who came into the emergency room with this rhythm. So my question to you is, what do you think this rhythm is, and how would you manage it? This patient was never previously known to have any medical problems known by anybody. So why don't we talk to Mohammed? What do you think, Mohammed?
Hi, good morning, Dr. Bass.
Morning.
So the rate is about above 200, 220, I think.
Mm-hmm.
Um, um,
It's actually
uh,
217. Sounds right.
217. Okay. Yeah. Okay. So the top.
Good estimate.
Um, so I'm thinking the small deflection right after each QRS is the like some sort of retrograde P wave.
Okay.
So I'll be looking at some sort of SVT, and if I'm seeing a P wave, then it's probably above the 70 milliseconds that we use in a cutoff for AVRT versus the AVNRT.
Okay. Now, let me ask you a question. If I just said to you, 2-month-old is having, so you're suggesting either ORT or AVNRT. What would the normal heart rate be in a 2-month-old who's in ORT or AVNRT, do you think?
I think usually above 220. Like,
In a 2-month-old? I think in a 12-year-old, I would agree with that, or even a 14-year-old. But how fast do babies have SVT usually when they're having ORT or AVNRT?
um,
It's actually quite a bit faster, right? So usually closer to 300 beats per minute in a baby, a newborn, or a very young infant, maybe 250, 260, but not usually 217. So, in the old days when you couldn't shoot a picture with your phone and just text it to the attending at home, the fellow on call would have to verbally describe what they were seeing. And so I often think in those terms, if somebody just said to me, I have a 2-month-old who's in a narrow QRS tachycardia at 217, I would be wondering what that is, because that is a notably slow rate for SVT, for regular, garden variety AVRT or ORT. Now, I'm not suggesting it's impossible, and you get full credit for that possible answer. I think that's certainly in the differential diagnosis, but I would actually say in this case, it's probably not the case that that's what it is. And I think this is the reason Dr. Savli decided to post this on Twitter, because he knows all the regular easy stuff pretty well, like ORT and AVRT. Any other diagnoses this could possibly be?
um,
So when I look in lead AVF, it's possible that there are actually two P waves, right,
hmm,
for every QRS. It's hard to say for sure, but I actually think that there probably are.
yeah.
Not 100% sure. How could you be sure? What would be a good way to So you're standing at the bedside, the patient is stable temporarily. What could you do to help figure this out? I mean, one thing you could do is, of course, just try to electrically cardiovert the patient, but that may not, you'd rather not do that. Patient is awake. You don't have an anesthesiologist nearby. So how could you potentially either treat or make a diagnosis?
Sorry, I was muted. You can try adenosine and see if that
Yeah,
for you.
right. You could give adenosine and so what would happen if we were in ORT or AVNRT and you gave adenosine?
Will probably be terminated.
Right, tachycardia would terminate, although always remember that sometimes it terminates and then restarts very quickly. So it's always worthwhile running the strip while you're giving the medication. If the patient is stable, I always would recommend that you run a 12 lead rhythm strip as you're delivering adenosine because sometimes people give it, it stops, and it starts so quickly that if you don't have it documented on the ECG, you wouldn't actually know that the adenosine worked, and you might draw a conclusion about the responsiveness to adenosine that's erroneous. Okay, so right, so if you gave adenosine, what if this were atrial flutter? I mean, if this were atrial flutter, and I'm right about this being 2 to 1, then what does that make the atrial rate?
So it will be double, so like in the 400s.
Right. And so is that a typical atrial flutter rate in a newborn or a young infant?
I think it's in the range, yes.
Yeah, that's actually very typical to be that fast. And so actually that would be one option. What this could possibly be, I think this is 2 to 1, but this could be ectopic atrial tachycardia with 1 to 1. That's a possibility. Could be I don't think that's the case. I do think there's 2 P waves for every QRS, but it's hard to say for sure. It's also possible that this could be PJRT, right, with a very long RP interval. As you said, the if this is the retrograde P wave, then this R to P is very long. It's probably over 200 milliseconds, unless there's another P wave buried in there. Also, kind of just has this general sawtooth look to it in this inferior lead. Um, but you would want to okay, so let's say it was atrial flutter, and so you've given the adenosine, you see that there are flutter waves. So now what would you do, Mohammed, in terms of managing this? So the patient, has a transient block with the adenosine, and you have and it, of course, once the conduction recovers, the adenosine is gone, you're back to 217. Infant is screaming, doesn't like the feeling of adenosine. So how are you going to manage this now? So now you know that the infant is in atrial flutter and you're in the emergency
Sorry,
room and they're asking for your advice on how to manage this.
I think they can cardiovert him,
Okay, and would you use a synchronized or asynchronous cardioversion for this?
synchronized.
That's correct. And would you synchronize to the atrium or the ventricle?
The ventricle.
Yeah, you can only synchronize to the ventricle, but again, always want to synchronize for this type of arrhythmia because the last thing you need to do is put an R on T and cause VF, which I have seen, and I sometimes have shared a tracing of that from a center in Tehran, actually. It's a nice tracing. Um, okay, and how much would you give? How many joules per kilo would you give to treat atrial flutter in a 2-month-old?
I think that's a half to 1 joules per kilo.
That's right. You could give a half to 1 joule per kilo is usually effective for that. And actually, Leo Lieberman and I did a study many years ago when, the present defibrillators that we have are called biphasic defibrillators. It has to do with the manner in which the energy is delivered. And this was a major innovation over the prior technology, which needed much higher energy. So biphasic defibrillators have become the standard because they are more effective at delivering the energy to cardiovert somebody successfully. And we determined that for most forms of SVT, I think zero point 0.4 joules per kilo was successful, but I would agree, 0.5 to 1 joule per kilo. Sometimes I'm pretty straightforward and I just want to give 1 per kilo just to make certain that I've given a nice dose that has no chance of not working. And in fact, in the world of atrial fibrillation in adults, there's a whole group of people who feel that every patient should just get 200 joules for AFib. So and you know, one of the downsides of cardioversion is that it is a negative inotrope. So some would say that the less times you have to cardiovert somebody, the better. So sort of taking all those points together, I normally will give about 1 per kilo for any kind of SVT. But certainly the official recommendations are zero point 0.5 to 1 joule per kilo. So the important teaching point here is simply that although ORT or AVNRT can be this slow in a 2-month-old, it is unusual, and it is much more likely that in a newborn or in a baby this young that's only 2 months old, that the tachycardia rate in ORT or AVNRT is going to be substantially higher, like 260 to 300, might even be over 300 beats per minute. So when you get a call about a baby that's having tachycardia, and it's in this type of a range, you should be very curious and suspicious that what you're looking at is not going to be ORT or AVNRT, which, you know, is most commonly the case. So that was really the teaching point of this, is just the heart rate is on the slow side. So it's a bit of a tricky question.
Quick question, just what you mentioned about the that you saw, like you had a tracing where it did R on T. Was that
Uh-huh.
a case where they didn't hit?
Sync.
Okay, I was make or versus like a machine malfunction.
Yeah, no, it was, I'm glad you asked that question, Molly. I can show it next week. And yeah, they just didn't hit the sync button. And so the patient got a shock on a T wave. So Molly, since you asked the question, if that happened and the patient went into VF, what would you do?
I mean, you then would do unsynchronized. I mean, you do what you just did.
Would you synchronize it or unsynchronize it if you were in VF?
Unsynchronized.
Unsynchronized. But how many joules per kilo would you give?
You would do higher, so like 1 to 2.
No, for ventricular arrhythmias, it would be 2 joules per kilo.
Oh, 2 at minimum. Okay.
Okay,
Mhm.
so I'm glad you brought that point up, Molly. It's very, very important, and this is an error that I've seen done a few times, which is that people generally are afraid to give a lot of energy. I mean, it's understandable. It kind of goes against the nature as a human being to shock any other human being, and so the last thing we want to do is give too much. But remember always, when you're talking about a ventricular arrhythmia, 2 joules per kilo is the starting dose, and atrial is a half to 1. So if you were to have given, let's say in this case, you gave a joule per kilo, it accidentally was unsynced, you got VF. When you decide to shock the patient again, you have to turn off synchronization, and you also have to go up on the energy to 2 joules per kilo because now you're in ventricular fibrillation. Um, Molly, why would you you do it asynchronously for VF? Why not do it synchronized?
My understanding is because it's not an organized, like you want to like stop it and you're unlikely to, I guess the way I think about it is it can't get any worse, but you want to like stop it when you are doing cardioversion, unsynchronized, excuse me, cardioversion for VF.
Yeah, I mean, basically, the main reason is there's no benefit really. I guess the one benefit would be if it could synchronize to the QRSs, then you could be reasonably sure that it's not going to put another shock on a T wave. Okay. But the problem is that in VF, the ventricular signal, or I should say the R wave, because it's really just reading off the electrocardiogram, is so variable, right? In VF, you can have very fine VF with little signals or big signals. So what can happen is if you have it set at synchronize, it's not going to deliver the shock until the device feels that it can confidently sense the electrocardiogram and then properly put the shock in. And so what can happen is, as you said, it can be delayed in delivering the shock because it's having trouble. And it can actually be dangerous. And this is an important point when you're using synchronization, whether appropriately or inappropriately. When you're using sync, it's very important to look at before you start, charging and delivering, to look at the electrocardiogram and make sure that the device is able to sync. The most common way that we sync on defibrillators is we use the electrocardiogram through the pads itself. And that works great. It actually turns out that the ECG on the monitor that you get through pads is usually very, very clear. But there's also an attachment I'm sure you've all seen for ECG stickers as well. You could do that as well. But you want to make sure that on the monitor of the defibrillator that you do see a little spike on top of every QRS and that the device can sense properly. The reason that's important is because if it can't, what can happen is you press the button to deliver the shock and nothing happens. And the reason nothing happens is because it's still searching for a QRS to time the shock after. And I have seen videos where somebody presses the button, it doesn't deliver. People don't understand what's going on because they obviously press the red button. And then they go to the patient and they start touching the patient to sort of adjust the ECG leads or whatever. And then the device delivers and shocks not only the patient, but the provider who's touching the patient. So always remember that once you press that button, the device is going to try to deliver the energy. And it might not deliver it exactly when you think it's going to deliver it. So, as you said, Molly, if you're in VF and you deliver it synchronized, it may not deliver it for a long time. So, it's probably unsafe to do that. But even when you're doing it appropriately and the rhythm is regular, if it's having trouble sensing, it may not deliver it. So, if you're worried, let's say you press the button to deliver the shock, nothing is delivered. The first thing you should do when you're trying to figure it out is turn off the defibrillator, or at least turn it into the ECG mode and off the defibrillation mode so that you can then safely touch the patient, make sure that the pads are properly affixed to the patient, make sure the ECG stickers are right, etc. It's a very, very important safety feature because, and the other thing I'll mention since we're talking about getting electrocuted, and I think most of you know this, but I'll just remind you, you cannot get shocked by an internal defibrillator going off. So if you ever come upon a patient who has an ICD and you are, the patient goes into VF or whatever, and you're starting to do CPR, it's safe to touch a patient who has an internal defibrillator and during an internal shock. Sometimes patients or patient families think they've been shocked when the defibrillator goes off because defibrillators will often capture skeletal muscle and the patient will jump to some degree. And if you're holding a patient or doing CPR, it can feel as if you were shocked because the patient literally moves when they get the energy delivery. But that is not an electric shock to anybody other than the patient themselves. So external shock, very dangerous to be touching the patient. Internal shock, no concern at all. Okay. Does that pretty much answer it, Molly?
Yeah, thank you.
Okay, thank you. Okay. This is a tracing from the cardiac ICU. They call you on post-op day 2 following congenital heart surgery. And my question to you is, what is wrong? How would you assess this? And how would you fix this? And this patient, I will just add, is being paced. So why don't we ask Dr. Upsikov what he thinks is going on?
Let's see. Are the pacing spikes turned off here, or is that a pacing spike kind of in the second lead? It's
I think that, so I would remind that this monitor is on so-called pacing modality. So it is augmenting the spike. And I don't know, these are simultaneous leads, the top and the bottom. I don't know why it only is showing it on one of the two channels and not both.
Is that lead the atrial, like the amplify?
It could be. I don't think so, though, because the patient was being paced. So actually, no, this is not an amplified tracing. It's a good question. Also, if it were amplify, it's on the V, right? It's not. It's
Oh,
right.
yeah.
So this is just I think this is just the pacemaker modality of the monitor where as you know, the monitors in the ICU can be programmed to sense a high frequency pacing spike and augment it. And the theory is that it makes it easier for bedside staff to know what's going on in regards to the pacemaker. And many of you heard me say how much I don't like that modality because I think it can be confusing. People confuse the spike with capture, which is not always, of course, the same. So, what do you think's happening here, Vlad? Is there a problem even? And if
Yes,
so, what would you do about it?
there does appear to be a problem. It looks like, in the earlier part of the strip here, you have a rate of about 150. And then when you start to have what looks like, missing beats, you don't have a QRS complex, you also have some hemodynamic changes there. So it is concerning. And then when you have recurrence of what looks like sinus rhythm, that fixes itself. And then it really becomes, it looks like it's almost every other beat for that where your pointer is right now. Yeah, for that like little stretch, it looks
Yeah,
like every other beat.
right.
And if it's truly pacing there, it worries me that it's not capturing. But I don't know, what is this? What is the pacemaker here set to? What kind of mode?
This patient is programmed DDD with a lower rate of 150.
Yes. So it looks like when it's like capturing or working, you have a rate of 150, and then when you're not getting the QRSs, you are still trying to pace at a rate of 150.
Right. Right. So this is actually a nice example of how the pacemaker modality is augmenting the spike nicely. But we see, of course, as you astutely pointed out, Vlad, there is no QRS following each pacing spike. And in case you thought this was artifactual, you appropriately noticed that on the A-line tracing that there is also a pause. And in this case, right, there's only a blood pressure on the the captured beats, not on the non-captured beats. So yeah, so this is a problem with ventricular capture. So how would you assess this in real time? Or what would you do? So you come up to the ICU, and you're at the bedside now. So how are you going to troubleshoot this, do you think?
I guess you could just try to crank up the output on the V wire and see if you start to have conduction that's consistent.
If you start to have capture, you mean? Yes,
Yes.
that's right. This could be, it might be that the patient just, the threshold changes. And so that would be the first thing I would do. So from a safety perspective, the first thing you'd want to do is crank it up to like 20 to see if you can capture at all and get back to normal hemodynamics or optimal hemodynamics. This type of situation, when you're that early after surgery, the most important thing, first of all, is to get the patient back to their optimal hemodynamics, which would be capturing on every beat. So the first thing that I would do if I came to the bedside is I would just crank it up to 20, just so that temporarily I know I'm capturing and that there's a QRS following every atrial beat. Okay, so now you're at 20, you're capturing. How would you determine the threshold one?
You could just start to slowly peel back and see where you kind of elicit a similar
Yeah,
finding where you're
that's
missing
right.
beats.
That's right. And in fact, what we determined the next morning was that the threshold had gone up slightly. I think the day before it had been like 3.5. No, I think it had been 2.5, and we were programmed at 5. But then the next day when we checked it, it was 3.5. So you could argue that at 5, it should have been capturing all the time. But remember that the threshold is going to change a fair bit. And that's part of the reason why we always program the device at double the threshold. It's the assumption of that is that the threshold you're measuring is not going to be consistent all the time. If it were, then it would make no sense to do it at double. You should just do it as, one-tenth of a volt higher or a milliamp higher than the actual threshold. And especially with temporary wires, which are, not sewn on very well intentionally, as well as the fact that they're being manipulated, the child may be moving, multiple people are going to the bedside and pulling on things. it's very typical that the leads can change in their threshold. Interestingly, in this patient, the threshold improved the next day after and was even lower. So, why, Vlad, are the thresholds not great in these leads, right? Like if I put in a permanent pacemaker, and I screw it in, I'm going to have a pretty good threshold, low threshold, and I can confidently say if it's good in the cath lab that it's going to likely stay that way for a long time. Why is that not true with these?
My understanding is the permanent leads that you put in, you kind of adhere to the myocardium, and then it also gets epithelialized and more secured, and there's kind of more contact with the leads in the myocardium. Whereas with these temporary leads, they're often like epicardial, or there's sometimes like edema or swelling postoperatively that can also change
Yeah,
their efficacy.
right. I mean, basically, the leads are put in to work, but remember that another important aspect of these leads is they need to come out at the end of the hospitalization. And so the surgeon intentionally doesn't sew them very tightly to the heart. I mean, I put pacemaker leads in, but I think we would all agree that Peter Pastushko is a much better surgeon than I am. And so, but his temporary leads don't work as well as my permanent leads. And the reason is because he is intentionally not sewing them very aggressively to the heart. And the reason for that is because at the end of the hospitalization, we want to be able to pull them out. And so it's a balance between making them touch the heart adequately so that you can have capture and sense and use them in critical periods, such as this patient is seeing. But the other important factor is that, the surgeon is thinking, I got to pull them out. And this is one of the reasons why atrial leads in particular can sometimes be very dicey fairly early, because the atrium is much thinner walled than the ventricle. And so the surgeon is even more worried about potentially disrupting the atrium. Sometimes the atria in small children can be very friable, so it's not uncommon that atrial temporary leads will sort of fall apart as terms of their efficacy and effectiveness of sensing and capture fairly early, and ventricular leads usually work okay, but again, almost by design, the leads are intended to not work great for very long. So it's a balance between having effective, adequate leads that work and not having leads that can't come out. Now, sometimes when the nurse practitioners or the physician assistants pull out the leads, they don't all come out. And so I'm sure you've seen or you will see that there are some patients who will have retained leads permanently. And usually when that happens, typically what they'll do is just it'll snap off and a piece will remain in the heart or remain on the epicardial surface, and we just leave it alone because the effort to pull it out is far higher risk than just leaving it there. And there are some patients who, many decades after congenital heart surgery still have their temporary leads attached to the heart. There are obviously implications of that in terms of ability to have safe MRIs in the future. But on balance, the thought is, try to make the leads softly adherent enough that they do come out. But if they break off, which does happen, I think it happens here too, maybe once a year. Not really a big deal. We just usually leave them behind. Okay. I think with that, we'll stop for today. I'll see everyone at sign out and hope everybody has a great day. Take care, everyone.
Thank you.